I request now Dr. D. Ramamurthy sir for the challenging situations of Phakic IOL. Please. So,
Phakic IOLs. Dr. Partha gave an excellent overview of how exactly you implant a lens. These are some minor variations that I'm going to be talking about. As he mentioned, you are always scared of damaging the anterior lens capsule. That's the reason almost for the last 4 years I have given up dilatation of the pupils. As you can see, the side ports are made at 3 o'clock, 9 o'clock meridian, and subsequently I just fill in some saline so that I don't want any dilatation, make a 3 millimeter central incision, and subsequently I use a mixture of xylocaine and phenylephrine. And you get in these young myopes, usually you get an excellent dilatation just with this. Whatever extra dilatation you need, I inject cohesive viscoelastic, and because of this there is a further dilatation, you get a absolutely protected. And then of course the lens placement itself was very well described. And what I do after this is no irrigation aspiration at all like this is actually hardly an edited video, this is a real time video, so it just takes about a couple of minutes to do the surgery. And this is the haptics being tucked in, and then subsequently all I do is to go ahead and hydrate the main port as well as the side ports. And usually I always prefer making, and you can see the bolus of viscoelastic coming out as a whole. And once clear fluid starts coming out, that tells you that all the visco is completely evacuated. It has been well shown that during the IA only there's maximum chance of damage to the anterior capsule, and this step is again completely obviated. So no dilatation, no irrigation aspiration, but just that's the way I do it, and it works very well. And I am told that quite a few of others have also started adapting this method. And as far as most often you end up with results like this with an optimal vault, a well-centered phakic IOL. But then there are situations where there are challenges. That's what I'm going to be talking about. In a situation like this where the lens is not optimally placed, go ahead and rotate it as quickly as possible. A digital overlay, if it is there, that's a great idea, but otherwise you can even do it otherwise. And unlike in intraocular lenses, you can do this rotation at any point of time, but the faster the better. One very important factor that you need to remember is that when you are rotating these lenses, you are not introducing any power or taking any power. So the spherical equivalent of the residual refractive error should be nearly zero. That is, if you have -1 with +2 diopter cylinder, you are redistributing the power and it will work. But if you have simple myopia left over, a simple astigmatism left over, it's not no rotation is going to be of value, and either you have to exchange the lens or you have to do the treatment on the cornea doing a laser vision correction if it's a minor residual power that's left over. What if there is cataract after phakic intraocular lens? You can see if it is nuclear sclerosis, then the lens is not really at fault, and you can just take out one haptic, and with a hand over hand maneuver, just with a 2.4 millimeter incision, these hydrophilic lenses or the collimer lenses can be brought out quite comfortably. Most often there is an anterior subcapsular fibrosis. So you have to be very careful of the way you create the rexes, especially because most of these patients are highly myopic patients. You might even be implanting minus powered lenses. So obviously you want a good rexis overlap onto the optics of the lens because you don't want any PCO formation. So maybe if there's as far as the cataract surgery is concerned, to my mind the only challenge is you can see there's a -7 diopter lens that's going in. That's why it's a 3-piece lens. So be cognizant of the fact that anterior capsular rexis has to be done in a very methodical manner. What about low walls? It was classically said that 250 to 750 microns is what we aim at. Here you see 137 microns. Here you see 84 microns. Another set of eyes where there's 230, 189 microns. Nowadays, to my mind, there is no lower limit. As far as the anterior capsule is clear, even a sub 100 microns I do observe, there are cases which have been, once the center flow has come in, the fluid exchange between in front of the lens and back of the lens is there, then getting a low vault is really not a problem. Of course, in toric phakic intraocular lenses, if we get a low vault, there might be greater propensity for it to rotate. So getting the lens of the right vault is extremely important. But in case you get a high vault like this, you can see a 1.35 millimeters. It's not this which bothers me, but the angle which is bothering me, in the sense that it's a 1.47 millimeters. If it is a 3.5 millimeter anterior chamber depth, and if the angle is open, In this case, whenever you put a phakic intraocular lens inside, the angle narrows down by about 10 to 15 degrees. Obviously, this is not quite acceptable. This angle is likely to zip up and then cause a recalcitrant anterior angle closure glaucoma. So definitely this lens has to come out. We have done everything right. There can be a whole course on sizing of these lenses, but suffice it to say, for example, this lens was 12.6 millimeters with the white to white, and toric myopic what we implanted was 13.7 millimeters. We overruled because the high volt and ordered for a 12.6 millimeter, and actually the company warned us that you are selecting a longer wrong overall diameter, but because of the experience we went ahead and implanted a 12.6 millimeter. Same thing with the other eye, where eh, though the Oko's nomogram indicated a 13.7, we had to exchange with a 12.6 millimeter, and what you find after the exchange is a little suboptimal vault but quite adequate, where you find a 323 and a 532. So please remember, a higher vault, especially with a closed angle, is much greater risk factor than a lower vault, and do not hesitate to exchange these lenses even though the formula might tell you otherwise. And toric phakic intraocular lenses in corneal ectasias, whenever there is stable keratoconus which has been already cross-linked or because of aging, and a patient has good spectacle corrected visual acuity with a centered cone, that would be an indication. Please remember, these phakic intraocular lenses do not take care of higher order aberrations. So if the patient required uh, uh, hard contact lens or a rose scale lens or a scleral contact lens, he or she is not a good candidate for a phakic intraocular lens. So here is the situation to us. Essentially, CXL or a topo-guided PRK with Intex stabilizes the cornea, improves the best corrected visual acuity. The subsequent step of toric phakic intraocular lenses improves the uncorrected visual acuity. So a situation like this, a iatrogenic ectasia minus 3.5 with a minus 5.5 cylinder, subsequent to CXL, is a good candidate for toric intraocular lens because you see a very regular bow tie and a well-centered cone. And this is basically the surgery that's being done. You can see the intact segment over there, which was done almost a year earlier. Nowadays, I would not hesitate doing it 6 months after stability of the refractive error as well as the topography. And otherwise, the surgery is no different. And here you are not looking at absolute accurate refractive correction, but debulking the residual refractive error. A situation like this of a keratoconus, you see an inferior cone, and you look at the refractive error of minus 4.5 with 4 diopter of cylinder. Obviously, this is not a good condition. And the decentered cone is less than 3 millimeter. The nipple of the cone, or more than 50% of the cone being outside the central 3 millimeters. In these cases, what we'll do is a topo-guided PRK treatment. Basically, this is what has been done, where you do a laser treatment to flatten out the steep area and laser peripheral to the steep area so that you get a much more regularized cone. The best corrected visual acuity also improves, and now this patient is ready for a phakic intraocular lens. And just in case you implant a toric phakic intraocular lens, you have to remember another important factor in mind. As far as the AC depth is concerned, the center, especially if it's a well-centered cone, you might get an inappropriate AC depth, and the periphery might be quite shallow. So essentially, what we do nowadays is that go down by about 2 steps in a case of Indian phakic intraocular lens. In a case of a star ICL, go down by 1 step, that is 0.5 millimeters, and we find that these lenses work quite well. This is just to show you a high volt in a case of a keratoconus, what we already discussed. So the fellow eye also has a high volt, especially in the first eye because it's angle narrowing. We went ahead and did a phakic IOL exchange, and otherwise this is exactly the same as what I showed you earlier. Only thing is, because of the crowding of the anterior chamber, the surgery is a little more challenging, but it's doable. And especially if you get a high wall with narrow angles, it's important that you go ahead and exchange these lenses as quickly as possible. Post-DAL, post-keratoplasty, in case high astigmatism is obviating the refractive outcome, then you can go ahead and implant a phakic intraocular lens. This again is a situation where you are not aiming at refractive accuracy, but debulking the amount of astigmatism. Very often the results of these are very satisfying both to the patient and surgeon. Last of my videos, just a one-off case done years back. That's a 3 millimeter incision. I'm going ahead and injecting the lens, but as you can see, the entire incision is opening up. It's extending. It was essentially a case of a brittle cornea. As we go along, we'll see that even the side ports open up, and this was one of the rare situations. The entire chamber was flattening up. I had to go ahead and suture up the incisions, both the main port as well as the side port. The patient himself or herself was quite happy with the outcome, and a week later, she forced us to do the other eye with exactly the same kind of a scenario. Essentially, it's a rare complication, but you need to keep in mind sometimes the corneas might be giving way like this and need to deal with it in the appropriate manner. Obviously, even a laser vision correction may not have worked out in this case quite well because the corneal hysteresis would have been inappropriate. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy, for brilliantly showing all the variety of cases and challenging situations